Great.
Good evening. Thank you for joining us for tonight's educational webinar on keeping your feet healthy this summer. Tonight's speaker is Dr. Ralph Napolitano, OrthoNeuro Director of Wound Care and Healing. Dr. Napolitano is a double board certified podiatrist and wound care specialist physician, specializing in surgery and wound care of the foot, ankle, and lower leg. He was the first podiatrist in the state of Ohio to earn board certification and certified wound specialist physician. He remains active publishing and lecturing locally and nationally on wound care and healing. Areas of special clinical interest in research include medical and surgical care of foot and ankle, general wound care and healing, diabetic foot wounds, management of surgical wound complications, custom orthotics, foot analysis, and aesthetic podiatry and laser care. Please type questions in the Q&A box below, and Dr. Napolitano will answer your questions following his presentation. Dr. Napolitano?
Heather, thank you very much. And thank you everyone for joining us tonight. Hopefully everyone had a great July 4th holiday weekend. And here we are back at it, whatever we're doing, whatever part of the world that we are tuning in from. So my specialty, podiatry, it's a little bit different in that it focuses on a body region, not just an organ system. So specifically, a branch of medicine devoted to the study of, diagnosis, and medical and surgical treatment of disorders of the foot, ankle, and lower leg. So in Ohio, it's kind of interesting that we retained a small part of our chiropody heritage. So chiropody is a reference to treating the hand superficially as well as the foot. So this we do still, those of us that want to do that. So warts on the hand, nail disorders, fingernail fungus, all of those things podiatrists treat. It's kind of different. So again, my specialty, we treat a body region, not just an organ system. So we take care of dermatologic problems, orthopedic things, trauma, etc. In ancient times, okay, this sort of practice was certainly part of what doctors did. So if we go back a long time in Egypt, there's relief carvings of people taking care of feet on ancient Egyptian walls and different things. And Hippocrates described care for corns and calluses. Napoleon had a podiatrist, as did President Lincoln. So as things evolved, the first society of my specialty was established in New York just before the 1900s. Other countries followed. So this fabulous foot, lots of statistics. So we can talk about different things, what makes this body part unique and certainly very valuable. We can't live a healthy, productive life without them. Each foot has 26 bones, 33 joints, 100 tendons, muscles, and ligaments. Now, some feet have a couple extra bones. We call those accessory ossicles, so little extra bones in different places. This is not a pleasant, appetizing thought around dinner time, but feet produce a half a pint of perspiration daily from their 250,000 sweat glands. So that is a very interesting statistic that I think we can quickly forget if we are eating dinner. The average person takes 8 to 10,000 steps a day. So if we calculate that, we're going to walk this earth 4 times. That's a lot of steps, okay? Women experience foot problems a little bit more than men. And why that is, well, too small of shoes, okay, is a correlation, but not just that. It has to do with the foot structure and how the tendons, ligaments, and joints function in a woman's foot a little bit differently than a man's foot. So we have to take care of this pair of feet we have too, right? We need them to last a long time, a lifetime, really. So lots of things we can talk about, a big topic, but those of us that remember David Letterman, we're going to do a top list of sorts, sort of like a late night TV that David Letterman did with his top 10 lists. I think we have 6 problems that we'll discuss in depth. So our talk tonight will discuss what these problems are, how to treat the problem, and how to prevent the problem in the first place. Now, we're not going to get into traumatology. Now, we're focusing on healthy feet for the summer. So certainly feet are less clothed this time of the year, so sandals, etc., going barefoot, different activities. So obviously a traumatic injury of the foot certainly needs care, but that's not going to be what our focus is tonight. Okay, so Mr. Letterman, was very prolific with this top 10 list. So we're going to do a la David Letterman style top 6 of these common foot problems and what to do about them and keeping our feet healthy and happy this summer. All right. So number 1, fungal problems, skin problems of the foot, and some other things. So skin problems, dermatologic things. Nail fungus. The scientific term for that is called onychomycosis. Half of Americans will be diagnosed with nail fungus by the time they're 70. So it's caused by this microscopic plant, okay, a fungus that's found throughout the environment. Now, the shoe, when you think about it, that's one item of clothing we tend to not launder, rightfully so. Nice leather dress shoes, we're not going to do that, but keeping that environment clean and healthy is very important. We'll get into that in a little bit. So signs and symptoms of toenail fungus: nail thickening, a toenail deformity, discoloration, even odor, and uncomfortable if the nail wants to grow in a little bit because of the fungal nail deformity. Of special concern, patients with diabetes, circulatory issues, and immune problems. So fungal disorders in general, if we talk even about skin fungus, like an athlete's foot, folks that are a little bit immunodepleted or immunocompromised are at risk for these opportunistic fungal infections. Not to say they can't recover from them, but they're just a little bit more susceptible. If left untreated, this fungal condition can cause the nail to become deformed, and that can, of course, cause an ingrowing toenail, and that, of course, is not comfortable at all. So here's a little continuum of what the disease looks like. A mild sort of presentation. We have a little bit of yellowing distally with the nail, and as it gets more significant, a moderate case, we see this involvement about half the toenail from the front to the back or the back to the front. And in severe cases, you can see that nail is brittle, thickened, uncomfortable, and certainly infected by fungus. Okay. Not only fingernail or not only toenails, but this can affect fingernails as well. So people that work in wet environments, so people that do dishwashing, people that work, in waterborne or water heavy environments, so plumbers, etc., you can get this chronic sort of macerated nail bed that's prone to growing fungus. Okay, so how do we get this better? Well, just like an antibiotic helps with bacterial infections, antifungals help with fungal infections. Now, when we talk a little bit about oral medications, there's some caveats here. Folks with certain what we call polypharmacy issues, if they're on certain medications that don't agree with the fungal nail or the antifungals, and that's certainly a talking point. So we have to be judicious with oral antifungal therapy. We also have topicals. Okay, the better ones now that are available are better than what we had in the past. So they're almost as efficacious, and in some cases, just as efficacious, just as helpful as the oral medications. Even laser. Laser we have at OrthoNeuro. This sanitizes the nail bed, and over a series of treatments, laser toenail fungus care is quite successful. Typically, we use these treatments in combination. Okay, so a lot of times patients will pick laser together with a topical or laser together with an oral. We look at this synergistic approach, these two modalities. Lasers in medicine do lots of things. They help reduce scarring. They help with fungal problems in nails. They help with things in surgery, okay? Varicose veins, cosmetic things, and even hair removal, which is more of an aesthetic thing. But lasers we have at our disposal to do lots of different things. So combination therapy is quite effective for nail fungus. So how to prevent this in the first place? Well, anywhere where there's a lot of feet walking around, you're prone statistically to pick up something, just like germs in a classroom, if you will. So try to be a little bit judicious at your local gym shower floor, in particular, wearing shower shoes, flip-flops, etc. Now, if you look at pools at clubs or public pools or resorts, they tend to be a little bit more spread out, not as concentrated, and there's a lot of traffic, if you will, uh, that promotes certainly an environment that needs taken care of in a larger scale. So, as such, the clubs and pools that are outside, they're exposed to sunlight, etc. So it's not as concentrated as a gym shower floor. So I don't think folks need to be too hesitant to go barefoot at a public pool. Excessive behavior regarding that it just makes for not a fun vacation. So let's keep that in mind. Basic foot hygiene and nail care. So not only do we talk about foot health at OrthoNeuro, we talk about shoe and sock health. So where do our feet live? In a shoe, right? So keeping those shoes rotated, okay? So you're not wearing the same pair of shoes day in, day out. Folks that have jobs requiring work boots, that's a little bit of a talking point, sometimes challenging. I'm not suggesting to buy 10 pair of work boots, but to be cognizant, if you will. So sprays, ultraviolet shoe sanitizers, etc. Bleach alternatives today. There's lots of milder detergents that you can use that are alternatives to bleach to help with socks. Pedicure awareness, in quotes there. And what I mean by this, friends are a great resource for such things in the aesthetic world and even in the medical world. So if you go to a salon that's new to you, an aesthetic place that doesn't feel right, doesn't kind of, you feel uneasy, then don't stay there. Okay. Now, if you think about this is folks' livelihood, of course, and they have to take care of their shops as best as possible. They have to adhere to the state medical board, the board of cosmetology. So if things are not clean, that's not going to work or bode well for their business. So certainly, if it's a reputable establishment, the likelihood that you're going to pick up things at a reputable establishment is certainly lower. I've been doing this for a quarter of a century now, which is kind of interesting to say. But in general, the vast majority of my patients, both ladies and gentlemen that go to have their nails done, that's not typically a risky proposition. If you'd like to take things a little bit more cautious, what I tell folks, you can get a dry pedicure. So instead of using the whirlpool tubs that they use, you can forego that. Other places have a single-use sort of basin where they line the basin with something that's disposable, and they can get rid of that in between clients. Okay, so shoe and sock health, as I referenced. Socks this time of the year, feet sweat, of course, especially if you're engaging in an athletic endeavor. Socks with a little bit of acrylic or sports performance fabric, very helpful as it wicks perspiration away. Merino wool, a natural product, very helpful. Um, the idea of rotating things around with socks and shoes as referenced. Synthetics certainly can bode well in combination. Now, cotton, of course, is kind of the anchor product for socks and hose. That works fine, but it can tend to not be as perspiration wicking as some of these other materials. So cotton in conjunction with these sports performance fabrics are quite helpful. Product to the left, the trade name of this, the Steri shoe. I have this myself. This uses ultraviolet shoe or ultraviolet light to sanitize shoes. The newer version actually gets the back of the shoe, but the majority of pathology that affects nails and skin involves the forefoot. So that's where the majority of our sweat glands are. So a third of this takes care of a third of the shoe. The older style, the newer style does take care of the whole shoe there. Okay, so we're going to transition a bit from nails that have toenail fungus and fingernail fungus to athlete's foot. Tinea pedis is the scientific name. So again, same sort of microscopic fungal organism, microscopic plant found throughout the environment that affects the skin. Folks that have had this know that it's not a very pleasant thing at all. We have scaling and flaking of the skin, cracking between toes, blisters sometimes if you get what we call a vesicular tinea pedis, a vesicular athlete's foot. Okay, an interesting dual infection can arise sometimes where you have bacteria with fungus, okay? And this we see in immunocompromised populations. Usually both those organisms do battle one against the other. And in fact, that's how penicillin was discovered, the inhibition of bacterial genetics with fungus. But these two organisms can persist together. Fungus of the skin can spread to the toenails and vice versa, although nail fungus tends to be not as contagious, not as catchy to spread from nail to nail. Again, special concern for patients with diabetes, circulatory problems, or immunocompromised patients such as cancer patients on immune therapies and on chemotherapy, etc. And this is what this looks like. So classic type presentation here, scaling, flaking. The foot in the middle of the screen there, that's a hyperkeratotic athlete's foot, where you get this callousing type presentation. The foot to the left there, well, on the toes, you can see a little bit of blistering. That's vesicular tinea pedis. Folks that have psoriasis might be familiar with how this looks. It looks very similar, a psoriatic foot to a foot with athlete's foot. So treatment, similar, antifungals, shorter course compared to toenail fungus. I'll point that out now. Typical course for toenail fungus is 3 to 6 months, depending. On label, really 3, off label 6. If we need to get a little bit more antifungal activity. Oral medications, 2 to 3 weeks, usually jump starts things. Fungal creams and ointments, often in combination with a steroid. I will point this out, creams and ointments for nail fungus, not effective because you really need to penetrate that keratin layer of nail. The antifungals for nails have vehicles that help that medicine penetrate, but that's not a cream or an ointment. And again, just like nail fungus, we talk about shoe and sock health being quite important as well. All right. Similar type presentation or similar type preventive measures here. Avoid going barefoot excessively in public spaces. We talked about that. Not to be overly terribly concerned and not to ruin your vacation about going barefoot around a resort pool, but really the gym shower floor, dorm rooms for college kids, that sort of thing. Smaller communal environments with more concentration of folks, more prone to such things. Again, basic foot hygiene, drying your feet thoroughly, especially between your toes, definitely helpful for prevention. If you do perspire excessively, controlling that perspiration is very important. So there's certain products that are designed specifically at this or for this problem, or you could use just a straight up antiperspirant and just earmark that for your feet. Okay. Again, shoe and sock health, pedicure awareness, and overall just general common sense hygiene things. Okay, so moving on with our skin problems here, we covered toenail fungus and we covered athlete's foot, fungal infections of the skin. Now we have plantar warts. So these are viruses that affect feet, just like they can affect other parts of the body, literally all over the body. Plantar refers to the bottom portion of a foot, the plantar surface. So that's where this name arises from. They look like a kind of cauliflower-like mass when able to grow and populate. Uncomfortable because you're walking on such things, although you can get warts on the top of feet and other body parts as a reference. You can see them on your toes, etc. Uncomfortable when walking and weight bearing. We see this more common in kids than adults, but you can get these at any age. Okay, and that's what these guys look like. Pretty significant example. Picture on the bottom right. The dots of the warts, okay, the quote seeds of the wart, those are actually little thrombosed capillaries where your immune system is fighting the warty growth particle or fighting the wart particle. And what happens, these little thrombosed capillaries, they clot off and it forms like a little infarct, if you will. So that's what you're seeing there. If left unchecked, they can really grow and populate, and we have a pretty miserable situation. Person on the right there. Okay, how do we treat these? Well, topical medications. So a lot of these are acid derived and acid based. If you have conditions, folks that are neuropathic, that have sensation loss because of diabetes, because of other conditions, even like a spinal cord injury or a back problem where they've had back surgery and have a little bit of numbness with one foot or both, have to be cognizant, because anything that we use that could be potentially caustic, if you will, or irritating, you might not know that. Your protective sensation, if it's compromised, can be a problem. So just again, using such things judiciously and checking with your physician team about them. Non-invasive procedures, laser, ultrasound, and some other things. Now, laser, again, our laser at OrthoNeuro takes care of plantar warts quite effectively. Laser is what they do with heat and light energy. They basically cut off that blood supply and basically eradicate the wart at its source. And why I say it's non-invasive, because we're not cutting through tissue. We do induce a thermal injury that does need to heal, but it's not a traditional excision like bullet point 3, which is certainly used. And on occasion, folks that have a significant case of these, we don't have a choice but to do a little minor procedure either in the office or in an outpatient setting where we excise that warty growth. We use electrocautery to kill whatever's left behind and to start those patients along their healing journey free of their plantar warts there. Okay. Prevention, all right, similar to our other foot hygiene things, all right, common sense when we're outside at our local gym, all right, communal showers that are closer type environment. Controlling perspiration also helps with these guys too. Shoe and sock health, as we talk about, and pedicure awareness. Okay. So still part of the skin, all right, but kind of its own dotted line to a skin appendage. This is number 2 here, ingrown toenails. Very, very, very common. We see this a lot, especially in kids. I'm doing ingrown toenail procedures weekly at OrthoNeuro. It's a condition in which the nail curves in, causing pressure and pain and possibly infection if the skin is broken. They can be caused by a traumatic injury or a chronic condition where the nail just grows deformed over time. A little bit of anatomy of a nail, whether it's a finger or toenail, doesn't matter. We have our nail folds, the inside or the outside. We say that's lateral or medial, depending on if it's closer to the midline of the body or closer to the outside of the body. We have the matrix, okay, which is the cellular area where your nail grows from, okay, and that's covered by a proximal nail fold. And you have this lunula, which shows you kind of where that demarcation of metabolic nail cell activity is, the closer portion to the nail. The onychodermal band, that's kind of where the junction of the nail plate lifts off and the nail grows distally there. And this is what this looks like. Ingrown toenails, different examples. The one on the top left shows where those edges just sort of pinch a little bit versus one that's very curved on the top right. And then we have a situation where the nail has actually pierced the skin, causing an infection there. We call that a paronychia, which is the term for an ingrown infected toenail. Okay, so how do we take care of these? Well, removing the offending nail border. It's literally like a foreign body that's causing a situation in which the nail pierces that skin, and in order to remove that infection, we have to remove that foreign body. So we can either take the nail border out temporarily or permanently. We can do a little surgery and prevent that side from growing in. Antibiotics in many cases are very helpful when we have an infection, like that picture that was referenced in the middle there. Basic wound care, simple things that don't take a lot of effort after we do a procedure. Prevention, avoid excessive rounding of nails when trimming at home, and avoid trimming nails too short. So when we're trimming our nails, you want to trim them more straight, if you will, versus curved. You can curve them a little bit, but too much of a curvature will cause the nail to grow in. Tighter shoes, pointy toe box for the ladies out there, not the best thing to do. That can cause all sorts of problems, one of which is certainly ingrown toenails. Okay, so that's our ingrown toenails. Before we get into some orthopedic things, what we do at OrthoNeuro, sometimes folks have an ingrown toenail and it really isn't one. So we start things with a discussion and a consult first, with some education. And then we have some decisions to make. Where I referenced, we can remove that offending toenail border either permanently or temporarily. It depends on how chronic of a problem this is. If someone keeps getting these, then certainly we can offer them that minor procedure that kills the side of the toenail to prevent it from coming back. Or if it's kind of a one-off, a little injury, or a weekend warrior that's engaging in a marathon, where the nail, after repetitive micro trauma, caused the nail to pierce the skin. And in those cases, we can just remove the nail, that nail portion temporarily, and it will grow back, hopefully normally. Now, when we do this sort of procedure, the goal is certainly to preserve normal anatomy. Folks ask me all the time, was my nail going to look funny if we do this surgery? Well, that's our goal, to not have that happen. So remove just enough to take that curvature out, but preserve the rest. So cosmetically, it's hard to tell we even did this. Okay, so we're about halfway through our talk, moving into the orthopedic space. Foot and toe deformities, bunions and hammer toes, very common deformities of the front part of the foot and the toes. A bunion is a deformity of your big toe joint in which the toe turns in, if you will, toward the other toes, and the first metatarsal head is more prominent. So the ball of the foot bone there is this knob that's on the inside of the foot. The result of this is an imbalance between the tendons and ligaments that help the great toe keep in line, if you will. So why do these happen? Well, biomechanics. So a flatter foot type. I had a professor in my medical college who would say a flatter foot type is like a floppy bag of bones, and a higher arch is like a rigid lever. So flatter foot types are more inflexible. Okay, with rigidity of the calf, that also causes a lot of problems. There's a term called equinus, and that has roots in Latin for horse. Think of a horse's leg, how it's kind of bent a little bit. Folks don't have calf flexibility. That causes all kinds of imbalance with the tendons and ligaments that move toes up and down. So having a flexible calf, we like it to be past 90 degrees by a few degrees, 10 degrees or so. That flexibility certainly helps. So keeping your calf flexible is one way to prevent this problem. We can't run from our genes like everything else in medicine. Genes play a role, but we can help them. We can help these problems and improve upon our genes with certain habits we'll get into. So here is our bunion deformity. It shows where that big toe joint turns in towards the smaller toes, and that metatarsal head goes out towards the inside of the body's midline. So you have this knob there. Okay, so here's some examples. You have a very significant example of bunions and hammer toes, where those toes are actually over top of the big toe, a lucky toe, which is unlucky in my book. You have a significant deformity of that big toe joint. You have a more milder case to the left, just where we have that metatarsal, that ball of the foot bone, slightly more prominent. And then the photo in the middle shows about a moderate to more severe type presentation. So here's x-rays. On the left, you can appreciate the foot on the right, maybe not as severe as the foot on the left, that bilateral view on the right, versus the picture on the right, the x-ray on the right hand portion of your screen. We actually have a subluxation where the lesser toe joint, that second toe, that's completely dislocated, a very significant deformity. So that requires some complex operating to get that back down with different orthopedic techniques, soft tissue releases, tendon balancing procedures, and temporary or permanent fixation with hardware. A little bit of anatomy here too. Those two little seed-like bones, those are called sesamoids. And literally that's from the Arabic seed. That's what seed is in Arabic. And they're about the size of orange seeds, give or take. And they're kind of like ball bearings. Your flexor tendon that moves your big toe down goes right between the sesamoid bones there. So when that's not in balance, those sesamoids drift in, and that causes further imbalance and further deformity and subluxation. Bunions are a form of arthritis. It's kind of a chicken or egg story. What came first? Some folks with their arthritis are prone to bunions and vice versa. But over time, you can appreciate if that great toe joint isn't tracking well and moving well, it's going to cause some erosions along the cartilage there. And that is certainly a significant, more advanced problem. Okay, so what do we do about bunions? Well, shoe gear and activity modification in a kind of an accommodative fashion. So sort of a celebration of the obvious here, but wearing shoes with a wider toe box and shoes that fit. Now, there's a certain point where shoe gear, we simply can't accommodate a significantly deformed foot like that, and then we have some choices to make surgically. For inflamed bunions, anti-inflammatories, pain creams, etc. Wear and tear arthritis, which, as referenced, bunions are a form of arthritis, or they can be a harbinger of arthritis, if you will. Typically, wear and tear arthritis is non-inflammatory early on, but as the disease process progresses, we have inflammation that can set in. So that's where we get into our anti-inflammatories, which of course help with discomfort as well. Surgery, of course, we can rebalance everything and put things back together. So this is an example of some bunion surgeries. There's many techniques in the literature. If you want to do a scientific deep dive, there's various degrees of patient commitment requiring recuperation and various degrees of success. So the less involved procedures have less recuperation but aren't as effective versus the more involved procedures. Biting the bullet per se early on allows the surgeon to really correct the deformity long term. The goal certainly is to fix bunions once, but depending on how old a patient is, it's not terribly uncommon to have to redo this in 20, 30 years if they have bunions like this in their late teens and early 20s. But of course, the goal is one procedure for life. This is a procedure that involves the distal portion of the metatarsal head, removing the redundant bone, which doesn't grow. It's just an architectural misplacement. So we have to remove that redundancy. And in this case, this type of procedure, we're realigning the joints at the distal portion. And that's what that looks like. Okay, that heals well. You have one solitary screw there. Again, various degrees of effective bunion surgery, less involved, less of a recuperation, but not as effective. We're getting better at minimally invasive things. The more involved, the more time you have to be off your foot for bones to heal and for those joints to rebalance. Okay. So avoid tight-fitting shoe gear if we're talking prevention, narrow toe boxes, high heels. So a shortened Achilles causes, again, all sorts of problems. So we have to have that flexibility, certainly, to help the foot function biomechanically. Arch supports, both over-the-counter and custom things that we can coordinate at OrthoNeuro, help to slow the progression. And as referenced, we can't outrun our genes. Genetics do play a role. Complete prevention may not be possible if someone looks at, their grandparents and their great-grandparents' feet. If they've had these, that might be in your future. It's just something to be cognizant of and to do these other things as preventive measures. Okay, so that was our bunion talk. Hammer toes is a contracture and bending of the smaller toes, one or both of the joints. Okay, second, third, fourth, or little toes can be malaligned and curled up or curled down. Again, this is an imbalance of biomechanics. So either the ligaments that move toes down are overpowering the ones that move them up, or the ones that move toes up are causing this buckling, if you will. This is uncomfortable, certainly in shoe gear. These rub, causing calluses and even open sores, ulcerations. Again, I keep referencing our our diabetic patients or people with neuropathy are not going to know sometimes. This protective mechanism, the pain receptors are not functioning in people that have neuropathy in more severe cases. So they don't know, that trip to Cedar Point or, walking around the mall sometimes get a little red area. And then over time, if that's not looked at, you can break the skin and that can cause all sorts of problems. Again, more common in women than men because of women's foot structure. Shoe gear choice does play a role, but it just has to do with flexibility and biomechanics of those foot types in women versus men. So this is a hammer toe, a little cartoon. So we have the ball of the foot joint at the bottom there, and then each toe, each smaller toe, has two joints. We call these phalanges, these little bones, and phalanx is a term for one single bone. So we have a proximal phalanx, a middle phalanx, and a distal phalanx. And you have different deformities at different levels and different bucklings, if you will. So and this is what this looks like. So the curling of the toes, the overlapping, all of this that can become static over time, meaning they're not reducible, and that's almost impossible to deal with conservatively unless you're able to accommodate the deformity. So how do we take care of these things? Well, shoe gear and activity modification, padding options. So there's different hammer toe pads or non-medicated silicone sleeves to slide over top of toes so they don't rub. I say not medicated pads as a universal precaution because medicated pads have salicylic acid or similar type products that really all they do is just sort of dissolve that top layer of skin. Well, again, folks that have circulatory problems or they're neuropathic, meaning they have sensation loss, that can cause more problems than just dealing with the corn itself. So we have to be very judicious about that. Now, can folks use a medicated corn pad successfully if they're healthy and don't have these conditions? They can, but I think being more judicious in general is a good practice in these cases. Trained in Pittsburgh, and during my era of training, U.S. Air was a very popular airline, and it was a hub in Pittsburgh International Airport there, and I took care of a fair amount of stewardess patients, and I'll never forget this. She was a young lady, I think maybe 23, 24. She was a stewardess. And she got very overzealous with using medicated corn pads, and she wound up giving herself chemical burns on her toes, which we got better. But certainly, that's an example of a very healthy young person that had a side effect with medicated corn pads. We can use anti-inflammatories for things that are inflamed, if you will, pain creams. So hammer toes over time can become arthritic, where the joints actually wear out because of the lack of appropriate joint purchase, etc. So we have these thick corns and calluses, those need to be dealt with. So reducing friction in shoe gear as a preventive measure, but also removing that thickened skin with pumice stones or emery boards, etc., being cautious and judicious. But those thickened layers of skin can actually cause sores underneath them. They can actually ulcerate. So that's something we need to be cognizant of. And then, of course, surgery to correct the deformity. All right, so here's some accommodative things. These little silicone pads. The device, the gizmo in the middle there, that's a crest pad, a hammer toe pad. So what that does, that causes the toe where it was buckled at the center joint to unbuckle. Okay, here's some hammer toe surgery examples where we're removing a small portion of the joint to align it and then using a what we call a Kirschner wire, pin to drive back through the couple joints that are involved into the ball of the foot joint to hold things steady temporarily. Again, lots of different ways to fix hammer toes, but this temporary fixation technique, that pin is removed and after a certain amount of time, and the joint hopefully stays what we call in rectus, in straight alignment, which statistically fixing hammer toes is a very turnkey, very predictable, very helpful operation. There is implanted hardware too, where you can use an internal wire or a construct, a threaded sort of headless screw to have that joint stay in line, stay straight. Okay, so here's some examples of that. To the right, an image of that little implant that keeps that hammer toe straight. This is a combination surgery showing a bunion surgery, a little bit more complicated one, a great toe joint fusion with some wiring to keep things straight. And then the picture to the left showing some implants in combination of decompressing the joints at the ball of the foot. Now, I'll point this out. I think we touch on this with arthritis, which is a talk in and of itself, but that surgery in the middle shows a fusion of the great toe joint, which may seem horrifying to some people if they're not aware of the benefit of this. But when you fuse the great toe joint, you obviously keep it straight. The flexibility then of the distal joint, that interphalangeal joint of your big toe, that becomes more flexible as the body adapts. So you can be very, very functional when you have a great toe joint fusion. Now, obviously, this is not thing you want to rush to do if you can prevent it, but this type of procedure is quite effective in orthopedics, and you have this foot that's aligned and still very, very functional. People can go about their day very, very active, doing sports that they like, and really they don't miss a beat. Okay, so prevention, hammer toes, just like bunions, right size shoes, good quality shoes, avoiding shoes with narrow toe boxes, excessively high heels, etc. Arch supports helping promote better biomechanics, and as referenced, genetics do play a role. And we will segue right into arthritis. Okay, we're moving right along. We have a few more minutes, a few more topics, and we'll get to Q&A. So we have two broad categories of arthritis. We have wear and tear that we all will get as we walk the planet 4 times, as referenced, how many steps we all take. And then we have an inflammatory sort of arthritis, in which case that is a different sort of arthritis that we'll touch on. So non-inflammatory is just wearing out of joints. Okay, this happens to all of us, and what degree and how much that progresses depends on activities, depends on injury, etc. Inflammatory arthritis typically happens in younger folks, lots of what we call collagen vascular disorders. So rheumatoid arthritis, more predilection for ladies. Gout, okay? Gout is a form of arthritis, a form of inflammatory arthritis, more men than women in different variants. There's more than 100 types of arthritis subsets. So a very broad category of things. So classic symptoms, joint pain and swelling and stiffness, deformity in the foot, the great toe joint, by far and away the most affected, as well as the ankle in the middle of the foot there. So this is a form of bunion, if you will, where the joint enlarges but maybe doesn't misalign. Okay, so we can appreciate the photo on the left there. It's marked right. That is where that joint is almost entirely obliterated. Well, ironically, when it's obliterated, you don't have much motion. And a lot of times when they're this advanced, patients have suffered through this process, this remodeling, kind of like the phoenix arises from the ashes. Then they're asymptomatic. They're not uncomfortable, but you have this bony knob that needs to fit in a shoe. So that's another discussion point that we have. There's an ankle arthritis picture up there showing what we call asymmetrical joint space narrowing, where part of the ankle joint is a little bit lower than the other. And then the photo in the middle, that radiograph in the middle, showing what we call a dorsal flag sign, where that great toe joint, it's hard for it to ride over top of that first metatarsal. How we treat this, shoe gear modification, activity modification, orthotics, a little modification with an orthotic, that's an arch support, where we add a stiffer, like finger-like projection underneath the great toe joint. And what that does, that serves as a lever. So you're not levering off of the joint that's affected, you're levering off of this finger-like projection that's almost like a springboard. If you have an inflammatory arthritis, of course, controlling the inflammation is paramount. Certain immunomodulators and biologics can help. Pain creams, steroid injection, and of course, surgery for arthritis. I referenced fusing of the great toe joint. That is a very tried and true orthopedic thing. The orthotic picture in the middle there shows that extension. We call that a Morton's extension. So that takes up the slack for the great toe joint there, if you will. Here's some surgery. Okay, this is a technique where we replace part of the great toe joint. We're still coming of age with some of these implants. All right, there's different levels of effectiveness in the literature. Again, still a work in progress. Replacing the ankle joint, which we do certainly at OrthoNeuro. That was a very challenging problem that the science community overtook quite well. It took years, but and with a significant learning curve with that surgery, not without its complications. But now we're at the point where that works quite well. So with great toe joint implant surgery, I can tell you personally that replacing half of the joint, either at the what we call phalanx portion or the metatarsal portion, that seems to be more effective, less chance of complications in the medical literature and in my hands compared to a two-piece or a stem type of implant in which you have basically replacing the joint. Now, stem type implants are replacing joints in knees and hips. Done it. We've been doing it for years and years, and that's very, very effective and very predictable. So that's a different sort of joint, different sort of biomechanical force there, entirely different from a great toe joint. Okay, now we referenced fusion as well. That shows a fusion with just two screws crossing a joint. Picture on the other side shows an implant where you're replacing part of the cartilage there with that looking type implant. Okay, so with this, controlling abnormal biomechanics, keeping your feet flexible and healthy, with doing stretches and wearing the right shoe gear, of course, controlling biomechanics with orthotics, medical foods, chondroitin glucosamine still being looked at, injection, etc. Okay, moving on. Problem 5. Okay, as we're taking our feet outside this summer, how we can keep them happy. Tendinitis, just a general term for inflammation of tendons at the joint of the ankle, at the toe joints, etc. So inflammation or irritation of a tendon resulting in pain, possibly weakness or instability. If the tendon sheath is involved, it's called tenosynovitis, mostly because of overuse, but can be related to a more acute time frame, so that weekend warrior type syndrome. Pickleball enthusiasts, go out and stretch a lot, stretch often, very important. I play myself, and in our league where I belong, I witnessed an acute Achilles rupture, a very significant one. This person, a healthy person in her 60s, tennis player, she probably had weakness there to begin with, was diligent about her stretching, but you can never be too flexible. Marker of longevity, certainly. So very important there to be cognizant. Most commonly in the foot, we look at the Achilles tendon as well as the posterior tibial tendon. That's a tendon that is related to forming and keeping your arch. So a little bit of anatomy here. The big tendon in the back, the Achilles, the one kind of that dives underneath the foot, that is the posterior tibial tendon. Then we have tendons that move toes up and down, the extensor and flexor tendons there. Okay, so anti-inflammatories and or steroids injections, very controversial, very proceed cautiously. So personally, in general, we do not inject the Achilles, the posterior tibial tendon sheath, with caution, but not often. Okay. Other areas can be injected. There's a subset of tendinitis that is very common that I'm sure when I get to that, folks are going to know exactly what I'm talking about. Shoe gear and activity modification and mobilization depending on the severity, and again, controlling biomechanics. Surgery, if necessary, as reference, if someone has an acute rupture or they have a tendon that's very attenuated, part of it can be replaced. Plantar fasciitis, as stated, that is a subset of tendonitis, very, very, very common. The plantar fascia is a ligament on the bottom of the heel. It's the most common cause of heel pain. So we have pain with activities and after periods of rest, more common in a flatter foot type, usually an insidious onset, but can be trauma related. Okay. Other causes, shoe gear or lack thereof, lack of arch support, certain activities, job type, weight, etc. So people ask me about going barefoot, if that's bad or good. Kind of neutral. So letting your feet do what they do naturally is very important. I referenced flexibility being a marker for longevity, a healthy lifespan. So being able to do everything you love as you get older into your 80s, 90s, and beyond. So keeping your feet flexible without shoes is important. Supporting your feet also very important. What I tell my patients, if they are orthotic patients, it's important to do some barefoot stretches and strengthening things in conjunction with wearing their arch support so that arch doesn't get lazy. Okay, so there's that plantar fascia. It's kind of like the appendix. It's not very useful, but pulling on the heel causes inflammation. You're all probably familiar with the dreaded heel spur. That grows as a result of inflammation, that pulling, but there's no surgical reason to remove that. It doesn't grow straight down. If it did, we'd be doing surgery on that particular part of the body all the time, but it grows within that ligament. So it's just kind of a radiographic clue. That's what's going on. So folks get better with heel spurs, and we leave the spurs alone when they're on the bottom. Now, when they're on the back of the heel, that can cause a problem where they kind of saw into the Achilles tendon. So that's a whole different sort of clinical scenario. Okay, there's our plantar fascia. Okay, so focusing on breaking the inflammation cycle and preventing it from coming back. Anti-inflammatory, steroid injections, orthotics, night splints, stretching your foot at night also helps, and surgery, okay, where we release part of that ligament. Physical therapy, where we use steroid cream to drive into the tissues. There's something called extracorporeal shockwave therapy, which is a very scary term. I wish it had a better name, but that has come in and out of favor. It's an insurance issue beyond our discussion here. It's not the easiest technique to find, but I've done it over the years. Our resources for this in the United States are a little bit limited, unfortunately, now, but hopefully we'll be able to get this technology back online. This is what that looks like, this extracorporeal shockwave therapy unit. Okay, and here's a surgery showing a release of the plantar fascia. Okay, now prevention activities as necessary with respect to orthotics, if that's something that is appropriate for patients that really can't get better with other things. Stretching, maintaining the correct weight, shoe gear awareness, and everything like that. Okay, our last term, our last condition, and then we'll get to Q&A, is nerve problems, entrapment syndrome. So carpal tunnel of the foot and ankle is called tarsal tunnel, and Morton's neuroma is an inflammation or entrapment of nerves between toes. There's also peripheral neuropathy. We talked about that. So people losing their protective sensation, vitamin deficiency, thyroid problems, and other things. Some nerve anatomy here. We won't belabor. Okay. Topical anti-inflammatories helpful together with steroid shots for these nerve problems, controlling abnormal biomechanics, and surgery when indicated to release where that nerve is entrapped. Okay, if there is an underlying cause, controlling that is certainly paramount. So diabetic patients controlling their sugar certainly will help prevent neuropathy from getting worse. Medications for treating nerve pain, medical foods. At OrthoNeuro, we've been using a medical food, a supplement, which is a doctor prescribed a reagent called Metnex, and it has to do with vitamin B complex, certain special formulations within that particular medicine that helps not just with nerve pain, but with nerve health and blood flow. Okay. So as we wrap up, common sense really prevails here, keeping our feet healthy this summer so they don't get in the way of everything from the beach to trips. We talked about going barefoot in public places, in particular gym shower floor environments and that sort of thing. Our shoe and sock health, not only foot health. Wearing well-made, properly fitting shoes is very important. We could have a whole discussion on shoes and fit, but going towards the end of the day helps because our feet are more dependent, a little bit more swollen. It's better to accommodate those swollen feet with our shoe fittings towards the end of the day. Then, after we rest, they'll be more normal size. Inspect your feet daily, certainly as appropriate. Don't neglect them. and addressing these problems before they get out of control. So with that, hopefully we were able to take away a few things if you tuned in, and I think we can get to some questions now.
Yes, thanks, Dr. Napolitano. The first question is, do you lose your nail with bad nail fungus?
You can. So over time, nail fungus that bad usually takes years to develop, as demonstrated in some of those pictures. So paramount, like a lot of things in medicine, is getting to that problem early. A lot of studies show that if you can get to treating your nail fungus within the first year, you're going to have a very favorable outcome. Folks that have had this for years and years and years that come to me that have had it for 20, 30 years or more, it's tricky. I personally feel we've not done this much of a literature or this much of a scientific review of nail fungus and nail plate damage and nail matrix damage, but I'm pretty confident there's a correlation. So you might be able to get your nail fungus under control, get rid of that microscopic organism, but what will happen though is your matrix, your nail plate is damaged, and that's hard to get better if untreated for years. So short answer, yes, you can lose your nail if it goes untreated over time.
The next question is, are plantar warts contagious and can they spread
They
to other
are.
body parts?
Yeah, so they're very, very contagious. Now, not to again be very, very fixated on such a condition, but they're quite contagious relative to nail fungus. Okay, athlete's foot more contagious than nail fungus. So warts are viruses, and we typically say there's a serotype for where they are on the body. So um, feet warts and hand warts a little bit different than other parts, but yes, they certainly can spread to other body parts. But typically, the serotype that affects feet are different than those that affect other body parts.
Can an ingrown toenail return after it has been permanently removed?
Hmm. Uncommon, but it happens. I have seen this on occasion. So statistically, if we remove the nail portion that ingrows, we have anywhere from a 90 to 95% success rate. So literally, I'll do a couple hundred of these a year. We may have to redo, a small handful, 5 to 10 to 15 maybe. And that's where that medicine that we use to get rid of the nail just doesn't take, or someone has a very robust nail matrix. In our practice, and this is pretty universal in podiatry medicine, there's something called phenol. That's the acid that kills the nail root. That's by far and away the most effective and very simplest way to do this. Now, sometimes if that fails, or if someone has a problem with that medicine for whatever reason, we can do what we call a surgical matrixectomy, where we actually excise that nail root surgically, and that requires stitching, and that's slightly beyond what we do in the office. That's an outpatient sort of thing, but that's a surgical matrixectomy.
What is the best way to cut your toenails to avoid ingrown toenails?
Yes. So in general, we say favoring straight across more so. You can round them a little bit, but if you cut them too short and too rounded, that promotes the nail from growing into the fleshy part of the skin on the side, the nail fold, if you will. So in general, keeping them slightly longer, not that you could climb a wall with them, if you will, but keeping them just a little bit longer and rounding them only slightly. So more straight across and rounded slightly.
If I have bunions, but they don't hurt, should I have them removed?
Mhm. That's a great question. If they do not bother you, then certainly there's not a surgical need. However, the rate limiting factor there is shoe gear. So if you have shoes that fit reasonably well and you're not uncomfortable, then certainly it's more of a cosmetic thing. Now, bunions tend to be progressive. So in time, they typically do get worse. So if someone is in their 40s, if they don't want to be dealing with this for their formative years, it's maybe something to consider as a prophylactic preventive measure versus having bunion surgery when you're in your 70s. it's a personal choice and a lifestyle choice, and frankly, a cosmetic appearance thing. You have to kind of sort out between you and your healthcare team there.
Can you fix claw toes?
So a claw toe is a variant of a hammer toe. I thought I had on this presentation the different variants of hammer toes. So it's buckling of two joints. So a claw toe, think about a bird claw, where the two joints distal to the ball of the foot claw around, if you will. There's something called a mallet toe. Think about a mallet or a hammer. So it's only bent at the distal joint there. Hammer toe, you get buckling more proximally, if you will. So these are just terms. So claw toe, hammer toe, mallet toe are all part of the lovely hammer toe clan and family. So all those can be fixed surgically. And I will say, hammer toe surgery in general, very simple recuperation, very easy, very predictable type of surgery. But all those hammer toe variants, if you can't accommodate them with sugar and padding, they can certainly be corrected surgically.
Can you treat big toe arthritis without surgery to stop the pain?
Mm-hmm. In the deck, I think I referenced an orthotic, which is an arch support, and something called a Morton's extension. So that is something that we do to prevent the joint from moving excessively in a shoe. And that basically protects the toe from bending excessively. So that's one conservative thing. Other things that you can do are medications, anti-inflammatories. Folks that can't take anti-inflammatories, other pain medications, simply Tylenol. We obviously want to be judicious about our narcotic use, which is, again, another separate discussion, certainly. Joint injections are also conservative. So medicines that you take, you put on, or you inject can all be helpful with great toe arthritis, together with biomechanical control, that Morton's extension orthotic accommodation.
Thank you, Dr. Napolitano. That was our last question. Any additional questions before we sign off here? Well, thank you for participating in tonight's webinar. Our next webinar will be held on August 13th. Dr. Craig Goubeau, OrthoNeuro's new hip and knee reconstruction surgeon, will speak on knee arthritis. Enjoy the rest of your evening. Good night.
Thank you, everyone.